as you can see, ADCs are really transforming cancer care, but they have these unique toxicities that are requiring really proactive monitoring. And so really the goal here is this multidisciplinary approach to care to be able to prevent toxicities and to mitigate symptoms when they do occur, to keep patients on therapy, but also while doing that, we want to maintain their quality of life. So to go over some of these main side effects. So as far as mucositis and stomatitis, it's often, I think, underestimated, but it can significantly impact nutrition, hydration, and it really, like I said, a patient's quality of life. We really always want to emphasize getting a baseline oral assessment on these patients. Look into your patient's mouth, see what's going on at baseline. We really want to encourage proactive oral care strategies. So the cryotherapy during infusion, dexamethasone rinses the week following treatment. And we really want to encourage our patients to report their symptoms early. Even mild discomfort should prompt an intervention before patients progress to really painful ulcers, which will require a dose modification. And just to kind of point out, for any grade 2 or higher mucositis, we need to hold therapy until the symptoms are resolved. And we're going to be focusing on maximizing all of the interventions. So the steroid rinses, clobetasol gel. Some patients, I've used liquid morphine for pain that's really severe, and really maximizing their hydration and nutrition supports here. And so then once symptoms resolve, then we can reinitiate treatment at a dose reduction. But really the take home here is prevention and early symptom reporting, which is key. For ocular symptoms, they frequently begin as a nuisance toxicity. So people will complain of dry eyes, blurry vision, irritation, a gritty sensation. But this can definitely become pretty clinically significant if it's ignored. So we want to be listening to our patients, encourage them to let us know what's going on. All patients really do need this baseline eye exam, but it really should not delay the start of treatment. So usually we want to get it within weeks to a month of starting treatment, but obviously the sooner the better. But again, it really should not delay the start of treatment for especially Dato-DXd, but the other ADCs as well. And we want to set the expectation that visual changes need to be reported early, and we all should have a low threshold for a referral to an eye care specialist, so an optometrist or an ophthalmologist for evaluations of these patients. It doesn't just need to be an ophthalmologist, so an eye care specialist. And just early supportive care really often prevents treatment interruption. So we're using preservative-free lubricating eye drops, 4 to 6 times a day. We're avoiding contact lenses during treatment. And then kind of the key escalating triggers you can see here, just persistent or worsening blurred vision, eye pain, discharge, any recurrent symptoms, any vision changes basically impacting their function. We need same week evaluations for these patients. As far as, respiratory symptoms that come up during therapy on ADCs, in thoracic oncology, I think pneumonitis until proven otherwise, because these symptoms can absolutely overlap with infection, progression, COPD, and even kind of past radiation effects. So any new cough, any new shortness of breath, any unexplained hypoxia, really, this is prompting an immediate treatment hold and an expedited evaluation. I'm bringing these patients into clinic for an exam and an expedited workup. We're getting imaging, likely CT imaging, and an infectious workup. And if pneumonitis is suspected, we're initiating corticosteroids early, and I'm using a multidisciplinary approach, working with the medical oncologist that I work with, as well as referring these patients to pulmonology. In regard to cytopenias, ADCs can often cause some of these neutropenia. So, and I think that neutropenia management starts with kind of anticipation. So for these patients, we want to make sure they know exactly when labs will be monitored, and really understand that, when they have a fever, it's extremely important to call in about that, not to wait on a fever, especially in the setting of low blood counts, white blood cell counts. It's equally important to have a clear after-hours escalation pathway so patients know who to contact immediately. At Dana-Farber, off hours, we have a page operator that they can call and get a hold of us. But we have a very low threshold for patients to page or call with any fevers or signs of infection. And just really just the key that timely intervention can prevent hospitalization and more serious complications. And then just kind of lastly, regarding GI-related toxicities on ADCs, especially diarrhea, it can escalate quickly and it can lead to dehydration, electrolyte abnormalities, and again, the approach is kind of early intervention. They just need clear instructions on when to start anti-diarrheas, how to maintain hydration, and kind of exactly when to call. We want to just make sure they're getting in plenty of fluids and calling if they're having 3 or 4 bouts of loose stools a day, and just a low threshold to bring patients into clinic to work up and give them supportive care. So just kind of the key takeaways here is just kind of with the ADCs, the goal is not simply managing the toxicity, it's recognizing symptoms early and intervening, promptly, kind of with the goal to keep patients safely on therapy when possible. And as ADCs, as the use continues to expand, there's like an opportunity here for us to move from reactive toxicity management to proactive toxicity prevention, and really collaborate as a multidisciplinary team to be able to give the patients that holistic, high quality care that they deserve.